Welcome everyone to this session, Global Town Hall, the 24-hour virtual town hall. I think that this is the 9th session, and good morning to everyone. At least good morning Memphis time. I guess folks are joining from around the world, so good morning. I'll have everyone introduce themselves, and then I'll start off with a bit of a reintroduction and trying to define implicit bias a bit and go through our talk. But if we can start with introductions, and Dr. Templeton, would you like to introduce yourself?
Sure. And thank you again for the opportunity to do this. I'm Kim Templeton. I am an orthopedic oncologist at the University of Kansas in Kansas City.
Awesome. And your subspecialty?
I do oncology. And
Yes.
as a side note, I'm also past president of the American Medical Women's Association.
Wonderful. Yeah, I think I'd seen that. Well, thank you so much for being here. All right, Rick.
Good morning, everyone. I'm Rick Smith. I am an orthopedic foot and ankle surgeon based here in Baltimore, Maryland. I'm in a private group, and look forward to the discussion.
All right. Ellen, you introduce yourself.
Yes, I'm Ellen Edens, and I am the odd duck here. I'm an addiction psychiatrist, and I'm at here in New Haven, Connecticut, and I work in the area of chronic pain and opioid safety.
Very good. All right. Well, I will begin, and I will start our session. Just being sure that we are live. Just as I'm getting text here, but I think this is our okay, perfect. Okay, well, thank you. Okay, so I'll go ahead and start sharing and reintroduce just a little bit here. As I start. So our talk is addressing implicit bias in the patient-doctor interaction. I want to thank Selene for asking me to moderate this session. I was excited to be given this topic. We have some excellent folks with us. So the overarching theme is driving change in orthopedics, leadership, innovation, and global collaboration. Oh. Yeah. All right. So I apologize. Maybe we are on now.
Did we just get left?
I think so.
I think so too. We've been deserted by our leader.
I'll be honest. I've been getting I haven't been following him, but I've been getting texts like things have. That I think there's been some technical difficulties, but maybe not.
I can certainly understand this. This is a huge undertaking.
See what's coming in now. Session 9 panel, please join ASAP. So do we all need to join? But I don't see anything that says join, right?
Yeah, I don't either. I thought we were in.
Yeah, I thought so too. Let's re-click on the link.
Maybe David's back?
Yeah.
Yes.
It looks like this is the right session.
And where's technical support?
They're still there.
I know, but they're not helping us much.
Let me re-click the link.
I have, can I conclude session 9 panel, please join. That was at 4:04. And
Yeah.
then it says,
Right.
you know, Mike was on here for a while. At 3:04, I saw Mike. Or because or whatever. I was here
Yeah.
like an hour early. He was here. Oh, the session is live.
Session is live. Can
Okay.
they see all of this?
We can't
Yeah.
see you, David. Just FYI.
Well, I'll try to get started. Do I have any reverberation now? Hopefully everybody can hear me. I'll try to get started again. Can everybody hear me?
Yes.
Okay. And can everyone see my screen?
Yes.
Okay. Well, hopefully we're live here. So this is Driving Change in Orthopedics, Leadership, Innovation, and Global Collaboration. The agenda tonight, I'll start. Dr. Templeton will give an implicit gender bias in healthcare. I'm still getting notes saying to please start. And then Rick Smith will give implicit ethnic bias in orthopedic surgery. Ellen Edens, Dr. Edens will give us implicit bias in pain management. And then there'll be discussion and Q&A at the end with the panel discussion. So this is our faculty. We've already introduced ourselves at the beginning. In case we weren't live, Dr. Templeton is professor of orthopedic surgery and associate dean at the University of Kansas. Rick Smith is faculty, Center of Advanced Orthopedics, Ortho Maryland. And Ellen is associate professor of psychiatry at Yale. All right. I'm being
David, your audio is a bit choppy.
okay.
No.
Seems like okay. How is that better?
Maybe just keep going.
Okay.
I would say.
I'm gonna have to get back. Yeah. All right. So defining implicit bias, and I think my audience maybe still, but it's attitudes and stereotypes that affect our understanding, decisions subconsciously. Develops over time through exposure to direct, indirect messages. Operates outside of conscious awareness. It's subconscious, and it can often contradict our explicitly held beliefs. So I feel often contradicts what we teach our children, what we try to impart to those that we love, how we try to live our lives. And it can contradict even those beliefs. In other words, it's biased when our brain makes quick judgments about people and situations without us realizing. It affects the way we act towards different folks and can manifest in healthcare as spending less time with certain patients and can make a difference in our treatment decisions, which ultimately affect patient outcomes, um, all while we're sincerely trying to treat all patients the same, or at least with the same level of care. There's a lot of data to support implicit bias and support its effects on patients and patient outcomes. So why do humans engage in implicit bias? Basically, faster decision making. It just makes life more efficient, allows us to move through our world in an efficient manner. So there are a number of things that play into implicit bias. Cognitive efficiency we just talked about. Social learning, there are hidden assumptions that happen automatically based on things we've seen or heard throughout our lives, like TV, family, school. Uh, Even when we consciously believe we're treating people the same. Um, In-group favoritism. This often occurs when we're trying to protect those that we love, those that are similar to ourselves. It was a tribal instinct that we had that helped us many years ago, but now contributes to violence. We also have limited exposure to diversity. All of us have that. None of us can be exposed to all our groups in an even manner. And so we all have limited exposure to certain groups. And so because of that, we form stereotypes and generalizations rather than using personal knowledge. And then confirmation bias. We all experience this. We tend to notice and remember information that confirms our existing beliefs and while overlooking other evidence, contradictory evidence, and it just reinforces our initial biases. And then inertia. We all experience this as well. We tend to favor the status quo, even when it disadvantages us, even when it works against us. We tend to want to stick to the status quo, stick to what we know. So we're here today. This session is all about the fact that implicit bias is difficult to recognize and it's difficult to change without deliberate effort. And that's why we're in this session, while we're having this panel discussion, is to try to have that deliberate effort and to recognize where implicit bias exists. So I'll stop sharing this window and turn off my mic. Dr. Templeton, I'll turn it over to you.
Thank you very much for that great introduction. Let me see if I can pull up my slides. And oh, well, trying to get the screen share to work. And well, unfortunately, my slides are not coming up. Oh. Well, I apologize. I can't get the slides, or my slides are not coming up. So if we want to maybe go to one of the other speakers, and I'll see what's going on with this.
Sure.
Yeah.
Rick, would you like to go now?
So Good morning again, and thanks again, David, for that introduction. So I've been tasked with addressing implicit ethnic bias in orthopedic surgery. And so the title of my talk is Out of Many, One People, and that'll become clearer why I chose that topic. All right, so I have nothing to disclose. However, the opinions shared are my own. And in all fairness, I am an early career foot and ankle orthopedic surgery. This is my first year of practice here in Baltimore, Maryland. So I think David did a great introduction in terms of going over definitions. I just wanted to draw our attention to some of the synonyms or similarity words in terms of bias. We talk about prejudice, partiality, favoritism, one-sidedness, intolerance. And so those are kind of some things just to hone our thoughts as I continue this talk. And then in terms of ethnicity, we're just talking about cultural subgroups and people that share some kind of background. So moving into my background, I'm a first generation Jamaican American. And so my immigrant story, maybe it's, in all fairness, maybe not as unique, but I consider it unique in terms of I immigrated here at age 15 for high school and then continued through my other forms of training. So, but wanted to tell you guys about my little island of Jamaica. I think it's known, and you all may have had interactions with Jamaicans, but our motto is out of many, one people. And this is the crest for our island. And it kind of shows or dates back to the history with the native Caribbeans, the Arawak or Taino Indians. And so despite all that and the history of colonialism, etc., Jamaica is made up of multiple different subcultures. And when I grew up in Jamaica, this is something I was well known of. Even though the majority are Afro-Caribbeans, I know Jamaican has a subgroup of German immigrants who actually speak the local dialect. We have Jewish Jamaicans, and so the list goes on and on. So growing up, this is something I embraced. This is something I learned, and I think it shaped my experience and my perspective. So everyone knows this guy. I've never met him personally, but like I said, he's well known. So that's just a shout out to my island. And so my trajectory in terms of moving around, after moving from Jamaica, kind of did my high school and undergrad training in Florida. And then after Florida, it took me to Pennsylvania, where I completed medical school. And then my training, orthopedic surgery, was at the University of Cincinnati College of Medicine, and went back to Pennsylvania for fellowship training. And now I'm here in Maryland. So I think throughout that all, being able to interact with different people groups and just ethnicities and experiencing different foods, etc., has really shaped and reinforced that cultural background that I mentioned prior. So the golden rule, and I put this picture on here just to harken back to, how I was raised. I was raised by my mom, single mother, but she is the nicest person ever. Like, she'd take the clothes off her back, and it was always reinforced to me, like, how would I want to be treated? And, growing up talking about the golden rule, treating people how you want to be treated, etc. But for me personally, as an orthopedic surgeon, and I kind of think about how would I like my mom to be treated if she were in the emergency room or the hospital or the clinic setting, as well as my wife, my daughter, my siblings, and just, all the people who I consider close. And so when I trained in Cincinnati, this is something that also got trained into me, or is the F-squared principle. Dr. Alvin Crawford, pediatric orthopedic spine surgeon, always talked about it, the F-squared principle. So did my chairman, Dr. Archdeacon, where we want to treat patients like they are friend and family. So that's something I take very dear, and I think it affects how I approach patient interactions. All right, so we have our biases, but we should focus on, or at least think, even though, as David mentioned, that implicit biases are, or makes it easier for us to organize our thoughts, but we, at the end of the day and in the background, we need to focus on finding common ground. So in order to kind of eradicate or try to limit or ethnic biases, we should think about identifying the barriers to care, avoiding assumptions, and then just asking questions, and then also understanding what those cultural taboos are. So the first item is language barriers, and I put in here translation services. So we need to identify where your practice, what are some translation services, professional translation services that are available. And then the other thing is, I know it slows our office clinic down and stuff like that, but trying our best to avoid using family member, even staff, because medical jargon is very different from local or conversational translation. And so there also might be different cultural ideologies in terms of delivering bad news or diagnoses, et cetera. So some of the resources that I found helpful is Language Line. That is a paid subscription, but even Doximity has a translation feature, especially if you ever have to call a patient. So just wanting to bring those up. The other thing is just ask. So names have varied pronunciations, and it might not be your phonetic tongue. So just ask patients how they want to be referred. And despite all the things that have been going on about gender pronouns and all that, it just makes, if you refer to the patient how they want to be addressed, then it helps to build mutual respect and build rapport. So other thing is social services, cultural groups, ethnicities. We're not monoliths. Like, yeah, it goes without saying. So there can be different resources concentrated at different parts in the community. And so if you're practicing in an area, I would implore you to kind of figure out, one, what is the cultural makeup and what resources are available for those patients. So, and last thing, understanding the cultural or ethnic taboos. So especially this goes into effect when you're consenting for surgery. And the biggest thing, and this goes back to what I said previously, using professional translations. Like I consider my second language to be Spanish, but I'm not fluent enough to consent someone for surgery in Spanish. So I always try to use a translator. And this also goes into effect when we're dealing with talking about, especially in the orthopedic realm, in terms of using grafts and the need for grafts and explaining where that tissue is from, because some cultures have different considerations about certain tissues. So, and then also for me as a foot and ankle surgeon, attitudes towards amputation, like that can be huge. And also understanding again what resources are available for those patients if they do have an amputation. Then lastly, in terms of attitudes towards the orthopedic exam, if it's an opposite gender or even same sex, but I put this in here, always better to have a chaperone than not. So this is one of the favorite videos and GIFs or GIFs, however you pronounce it. So again, harkens back to my cultural identity. So takeaways for this talk, and just, based on my own experience and what I would want people to take away, is we got to work on finding common ground. That will help to limit both implicit and explicit biases. And then never assume, always better to ask, and explore those professional translation resources. And then just think about that F-squared principle, friend and family. You can never go wrong. Right, so I'll finish up with this slide from, again, another well-known Jamaican. Thank you guys so much.
All right. Thank you, Rick. That was awesome. That was really good. And hopefully I have my audio figured out too now. So I love the Bob Marley quote. As you and I were talking about before, I can't believe he passed away at 36. He had a huge impact on the world for such a short life for him. And Jamaica certainly contributed a lot to this world in a lot of ways. And well, thank you for that. Dr. Templeton, would you like to? Yeah, there you go.
Yeah. So is that sharing now?
It is.
Awesome. Awesome. Well, and I'm sorry about the technical issues earlier, but thank you again for the opportunity to talk now about some gender biases. And I hope to live up to the previous presentation, which is awesome. Nothing to disclose. Are the slides advancing? So when we're looking at gender biases in healthcare professional and orthopedic surgeon interactions with patients, the gender biases actually come from multiple directions. It's the surgeon demonstrating biases when addressing patients, patients and their families having biases when they're interacting with the surgeon, and then healthcare professionals, including other orthopedic surgeons, demonstrating biases against women surgeons. All of these can impact patient care, and they also impact surgeon well-being, which in turn then impacts patient care. So what do some women patients experience? Well, we've heard, at least in the US, hearing more and more about medical gaslighting, where women feel as though
Dr.
their
Templeton?
concerns are not being taken seriously. That is quote unquote all in her head, especially of complaining about pain. But why?
Dr. Templeton, I'm sorry.
Yes,
The slides actually aren't advancing.
they
We're
aren't
still on
advanced.
we're still on your first.
Okay.
Let me
Um,
let me see. I see
It
your
looks like
slide.
you're in the yeah, you're not in the presenter mode.
okay. I was in the slideshow mode.
Yeah, but we were seeing the present. I don't know what we were saying.
Yeah.
Yeah, we were still seeing. So I think the presentation went to another screen. So
Okay.
if you were sharing your entire screen, just navigate over to it.
Okay. Is that advancing now?
You're
Yeah,
not sharing.
yeah,
Stop
we're not
sharing.
sharing now.
Okay. I'm sorry about all the issues. Let's try this again.
Yeah.
And is that, can you see?
Then slide over. If you're using a Mac, go to another screen.
Yeah, I'm
Um,
not on a Mac. I'm on a
you're not
PC.
on.
Yeah.
So yeah, I think I am seeing gender biases from multiple directions. So
Yes.
Mhm.
Okay. And then is advancing to the next slide?
No, it's not on your your sharing screen. When you go to share
Uh-huh.
your entire screen instead of sharing a window. That's what I did earlier. See if
Okay.
that helps. So stop sharing and then go back to share and share entire screen.
Okay. All right. Entire screen. Okay. Don't know if
yeah,
this
that
is,
one.
and is it advancing there?
Uh, so it's on gender biases from multiple directions.
Okay. All right. Yeah. So it's not advancing. I'm sorry. I'm not quite sure how to make this advance.
I got you. Clicking on that next slide, is that
Yeah.
so?
Let me try
Sure.
this. Let's see if I do. Next slide. Does that now to go to gaslighting?
Not yet.
No. Okay.
Do you see your notes page? Can you click on slide 2 on the side and see if that doesn't do it?
Yeah, so
There, we saw
that
it
just
change.
advanced,
Okay.
and that just advanced, and that did too. So
Yeah.
that's
Yeah. I can just do it from this mode rather than the entire screen mode, if that's okay.
sure. Yeah.
Okay.
Sure.
Fine.
All right. So can you see gender biases from multiple directions?
Yes.
Yeah.
Yes, ma'am.
Okay. So thank you. So sorry about all the technical issues. So again, patients or women can have experienced gender biases from multiple directions. Again, either the surgeon has biases against the patient, or the patient and their family have biases against the woman surgeon, or healthcare professionals have biases against the woman surgeon. All of these can impact patient care and surgeon well-being, which then impacts patient care. So again, what do some women patients experience? As I mentioned, the issue with medical gaslighting, where women feel as though they're not being taken seriously, especially if the complaints are about pain. And the circle on the picture on the bottom right just discusses the fact that a lot of the issue with gaslighting is that we just don't have adequate research to look at differences between women and men in a variety of health conditions. And so, is this an issue with cognitive efficiency, as Dr. Richardson mentioned earlier, that it's just easier at some level to think that there aren't any differences? Is it a blind spot where we don't realize that we should be looking for differences? So, a lot of the issue of the biases that women face is just based on the gap in the data. So, if we're going to improve patient care for everyone, but especially women, we need to improve the data. So, where do we stand with that? Well, the study on the left looked at studies that were published in orthopedics in 2016. They found that only 30% of studies looked at differences in outcomes based on sex. Over a third of those that looked found a difference. So, we know the differences are there, you just have to look. The results are similar to a study that we published in 2020 that looked specifically at rotator cuff injuries, where we really don't know much about sex-based differences because, again, we haven't looked, or osteoarthritis of the knee, where we know there are differences. And so what I wanted to do with this is to see, is there a difference if we know there's not an issue, so we need to improve the data, or we know that there is, so we should consistently be looking. Unfortunately, still only about a third of the studies, regardless of topic, looked at data based on sex, and there was no improvement over time. Interestingly, we did find that studies that had a woman as a first and or last author were more likely to look at results based on sex. So we're not doing a great job in the literature. And again, without this, we're not going to improve patient care for several reasons. One of which, without data, we don't have the material with which to inform care. But as we're looking at developing clinical practice guidelines to make care somewhat more uniform, or help inform care, without data, there's nothing to inform guidelines. And so these guidelines on pain that were published by the AAOS in 2021 noted in the introduction that one of the major limitations was that almost none of the studies that we utilized to develop the guidelines looked at data based on sex. Dr. Edens will be talking here in a little bit about the issues with pain. Not looking at sex-based differences in pain is a problem. The study on the right assessed studies to see if women did indeed have more musculoskeletal pain. Every blue bar is a study that showed women had more musculoskeletal pain than did men. So we know that women report more pain, but yet we're not looking at how they present and outcomes based on sex when we're looking at pain, and that extends to the vast majority of other conditions within musculoskeletal field. So flipping the coin then, what do women orthopedic surgeons experience? Well, one of the primary behaviors that women experience are microaggressions. These are statements or actions that are negative. They have negative, either verbal or nonverbal slights or insults that convey negative messaging, indicates that the woman isn't part of the majority group. These can arise from unconscious or conscious biases, primarily unconscious biases. These are repetitive behaviors that unfortunately are harder to identify than things such as sexual coercion or sexual assault or bullying, which makes them much harder to try to address. So, what's the prevalence of microaggressions in orthopedic surgery? This is a study of women in residency and fellowship or in practice. Only 8% of the women in orthopedics had not experienced a microaggression. In this study, they found that the most common perpetrators were patients and their families. Also then follow surgeons. So women, unfortunately, in orthopedics can face microaggressions from multiple sides. And again, this is something that they often face on a daily basis. Unfortunately, when the perpetrator is a family member or a patient, we often don't know what to do because we're there primarily to take care of the patient. So we often don't say anything because we're not sure how to respond. But unfortunately, the impact of these behaviors just accumulate over time because, again, we're getting these from multiple directions. And so what are some of the microaggressions that we face from patients and families? Again, more often faced by women than men, but it's often in the context of role questioning that we are assumed to be inexperienced, meaning that patients often don't adhere to recommendations, which means that they only not don't get better, but then it's frustrating to us because we're trying to treat them. They don't adhere to our recommendations. We can't, and so they don't get better, which then impacts how we're then dealing with them. This Medscape study on the right shows that the high prevalence of microaggressions from patients and families faced by women in orthopedic surgery, it's a little over 20%. This also can overlap with other biases and other identities, especially age. So often women orthopedic surgeons who are young are thought to be too inexperienced to know what we're doing, or that we're too old and we can't keep up with current treatment modalities. So lots of issues that what women are facing from patients and their families that impacts our well-being and impacts patient care. What do then women face from within the profession? Because this just adds to what we're facing from other sources. This was a study of sexual harassment using the broad definition, so including microaggressions of what women face in orthopedic surgery. The most common thing that we face are negative verbal remarks from men attendings and also then from patients. This does again have a cumulative effect over time. Other studies with across healthcare show that about 90%, at least 90% to or up to 90% of women will face this behavior at some point. But again, this is repetitive behavior. So the graph on the right, the purple bars are those people that have repetitive behaviors. And as you can see, their repetitive behaviors, as you go further to the right, just increase in prevalence with age. So, what do women see or experience in orthopedics? The things that keep them from the field are things like good work life balance, but the main things are things like culture, the need for physical strength. But when you're in the field, do you face anything different? No, this just extends to when you're in the field where there's no accommodation for societal gendered expectations, such as caregiving in the family, and especially this patriarchal culture that leads to gender stereotypes where men are seen as dominant and strong leaders and women are seen as gentle, caring, and weak, often leading to fewer women in leadership roles. And leaders can often set the tone for a department. An area where we don't think much about microaggressions during training is just procedural volume. This is not just an orthopedic issue. This has been seen across specialties. In our study that we published earlier this year, we did find gender differences in the number of cases that residents perform while they're in training. Better, but it's still there. But this also extends to practice. We have found that women orthopedic surgeons receive fewer referrals from men, other men in healthcare, especially if that referral is going to lead to a procedure. If there was no difference, so if a woman was the referring physician. So women get less experience during training, and then once they're in practice, are less likely to be referred patients who require procedures. So why does all of this matter? Well, when we're looking at the behavior within orthopedics, it can lead to a hostile or toxic work environment with a lack of respect. And what's concerning too is this blame culture. If women aren't respected and they're constantly facing these negative comments, if they see something going awry, are they going to feel safe to speak up to let people know there's something going on? Because are they afraid that they're just going to be blamed because they're not part of the majority group? There are also other significant issues with this. This is a study of general surgery residents. And what they found is that the women were more likely than men to report burnout. But if you then controlled for the inappropriate behavior they were facing or the mistreatment they were facing, the gender differences were much less. Suicidal ideation also more common among women, but there was less of a gender difference if you looked at mistreatment. And there was actually a stepwise increase in risk of suicidal ideation the more one was subjected to inappropriate behaviors. So the effect of these behaviors is a feeling of lack of belonging, because if you're constantly facing negative comments, then are you actually in the right field? Lower morale, increased risk of burnout, decreased well-being, and then the associated risks of depression and anxiety, and eventually attrition from medicine. So how do we address this? Well, in terms of the research needed to improve the care of women, there are lots of efforts going on to try to address this. This editorial was published in JBJS last year. This is a result of meetings of a group of editorial leadership within orthopedics to see how we make this better. And one of the recommendations was to improve these international SAGE, or sex and gender equity and research guidelines, so that we can more consistently report results based on sex. When it comes to the woman physician experience, is it do we just need more implicit bias training? This is a study we published last year in which we gave the implicit association test to orthopedic surgeons and those in training. Only a third of people had no preference. The other preferences were slight. There's only a 14% a strong association of women with family and home and men with work. Interestingly, this association was found to be stronger among the women participants than among the men. But this is not significantly different than other areas of medicine that have more women. So it's not just the implicit bias, at least measured by this test, that's the issue. So what is the issue? And that's something where we need more research. It doesn't mean we don't do implicit bias training or focus on implicit biases, but it's not just that, and it must be something more. But in the meantime, what can we do now? It's changing the culture, developing a supportive environment so that everyone feels that they belong. They understand the impact of microaggressions and what microaggressions look like and make those not acceptable. Training and prevention and recognition of these behaviors, whether they're coming from others in healthcare or if they're coming from patients and families, and identify how we can step in to help people, encourage women to speak up, and make sure that there are consequences for those that demonstrate this behavior, especially for those who are in healthcare. So again, I'm sorry about the technical issues, but thank you very much for the opportunity to speak.
Thank you, Dr. Templeton. That was excellent. I appreciate that. And look forward to a little bit of discussion here too. Ellen, you want to jump on? Oh, by the way, I feel like I need to say this. I said this beforehand, but then because of the technical issues, didn't say it now. But Dr. Edens is my sister as well, so I appreciate her staying up late with us. So, all right, Ellen.
David, it's not letting me share either. Give me just a second.
Okay.
Had everything already, and let me see. Browser's address bar.
Oh, I know the feeling. I was just there, as was Dr. Templeton.
Coming up, it's saying I need to right click. It won't let me share.
Huh.
It says, so I have to go into my settings for this and ask for screen sharing.
Huh.
Because
I think Dr. Templeton has stopped sharing because I can share my
give me
screen.
a second, y'all. I'm sorry.
No, again.
Okay.
So under the share, it doesn't give you the chance to do.
It did, but then I had come out just to make sure I could, and now it's not giving me the option to share anymore.
Oh, I'm sorry.
David, do you have my presentation by chance?
Yes, I do. Yes, I do. Yep.
Any chance you could pull it up? And I am mindful of time, and so I will rush through things. It was giving me something where I could share my screen, what you were talking about, Rick, and now that's not coming up at all, and I have to go through some settings.
You're on a Mac as well?
Yeah.
Yeah, so you'd have to go to your settings and privacy and accept share screen or whatever. Give it permission.
For this.
Mm-hmm.
So it's just in settings and then privacy.
So Ellen, can you see that now?
Yeah. Yes. Can we is that okay?
Yeah. So this is fine. You just tell me when to advance.
I will do that. So here I am, the psychiatrist, and I'm going to be talking about pain management. And maybe I've changed some things, David, since I sent it to you earlier, but that's all right. So let's get started. The bottom line up front is that all pain is real pain. And if there is an implicit bias, it's that we don't always believe that. Pain is whatever the patient says it is. It is inherently subjective. And I'll tell you when to show the slide, but you got it. Just go ahead and move on through. So yeah, so I like to tell this particular story to illustrate this to the medical students, because obviously when anyone is disbelieving of your subjective experience, it has impact on you, on your experience. It necessarily create tension between you and the other person. And so this happened my parents are in their 80s, and about 20 years ago or so, kind of their internal thermostat started to change, and my dad started being cold all the time. I think one day my mom was a bit frustrated with his complaining, and he said, "Oh, I'm just so cold." And she said, "Oh, Greer, you are not cold." And my dad was very polite about it. He kind of chuckled to himself, and he said, "Oh, well, thank you so much for telling me that. I thought I was cold." And then of course he went and got a hat and a coat and made himself comfortable. But this illustrates how absurd it is to question somebody's subjective experience. If it hadn't been so kind of generous and humorous, he could have gotten really upset, which I think is what what happens to a lot of patients. And so our role as medical professions, and you can push this, David, really is not to judge the validity of the pain, because it's valid, it's pain, it's whatever they say it is, but really to listen, to validate, and then to what I would say co-manage with you can push the next one, validate, and then third, co-manage with the patient. In large part, a lot of what we can do is simply hear the person. I hear you're in a lot of pain. I hear that you're worried about this. You're worried you're not going to get good analgesic benefit. How can we maybe work together, or what can be a plan? But acknowledging how a patient feels is really, honestly, the take-home message of this talk. Next slide. Another thing that I'll do with a lot of patients is talk to them, and certainly with medical students, about the neuroscience of pain. One of the things that helps us not get so frustrated with patients, or to check ourselves in a way, is to realize how much uncertainty there is in the field of neuroscience and pain. We just don't know so much. This slide, this little graphic, is taken just from Up to Date, but it's highly complex. You can really see it's not just about transduction and tissue damage, but you can see that there's a signaling to the dorsal horn of the spinal cord. There is signaling up to the thalamus for processing, up to this cerebral cortex where we actually perceive pain. And then there's an inhibitory pain pathway down. And anywhere along this pain pathway, especially for chronic pain, things can get disrupted, and the signal can be triggered really anywhere along that pain pathway. So understanding that, and I will often tell patients, of course, we believe that you're having pain. And then what they often will say is, "You're telling me that it's all in my head." And the truth is, what they're trying to say is, "You don't believe me," right? Because pain is all in our heads. It's not all in our heads, but it's everybody who ever experiences pain and thinks about it, acts on it, talks about it, it's working on the brain. And so understanding how complex this is, and finding a way to talk to patients, especially bringing in neuroscience, can often really help. Pain is a very complex biopsychosocial event. And I think we often get frustrated when we really only think about it as a biomedical event. But pain was meant for survival. It is meant to grab our attention. It's meant to elicit an emotional response so that we change behavior. And so that humility and some understanding can help me. Next slide. Now I'm going to cover some of what my colleagues have already covered, which is racial biases, and I'll try and do this very quickly. This is just one landmark study that came out, University of Virginia, looking at medical students and residents, and had them rate Black and white patients experiencing pain. I think it was case vignettes, and then they also provided treatment recommendations. They had to take a survey on beliefs regarding biologic differences, and push the next one, David. One of those beliefs, those false beliefs, and I have that in blue, in the blue box, was that Black people's skin is thicker than white people's skin. And this was actually a fairly commonly endorsed stigma. 50% of medical students endorse these false biologic beliefs. And when they did, those who had more false beliefs had greater perception of less pain among Black patients. And those who had more false beliefs also were less accurate in making treatment recommendations. Next slide. Next thing. These are just meta-analyses that show for over 20 years, minority groups do not get as much opioid prescribing. Might have been a good thing for a while, but it wasn't good reasons. It was really under treatment of pain. This was redone in 2024, showing the last 10 years where I think a lot of our, at least in the United States, where opioid prescribing was kind of rampant for 20 years. And now we're trying to do a better job reining things in, but we still are have these disparities in how we're using opioids, even in the last 10 years, and treating pain. Next slide. I'm going to just all this really is, this was another literature review that showed that there are disparities across healthcare systems, ERs, perioperative, primary care, and also for multiple pain conditions as well. And just that many of our biases are very unconscious. This isn't us explicitly being mean to each other, but as Dr. Richardson mentioned, I think all the presenters have mentioned, it's largely unconscious. And the main way that we combat it is by examining it, being aware of it, and really staying on top of self-reflection, I think. Next slide. So moving on to gender, this study came out in 2018, also a literature review that was of 77 articles that met inclusion, all related to pain. And what they really found was that there were differences across these studies in expectations around pain expressions. So society expects men to be brave. I thought it was a great title, and stoic, and women to be more emotional and expressive. And then there was also a recognition that there were different communication styles. So women tend to use more emotional language when describing pain and include a lot of contextual details, whereas men are more objective and use physical descriptions. The other thing is that a lot of women will use an unhelpful coping style, or more women than men will use an unhelpful coping style that really is unhelpful beliefs or cognitions. It has been called catastrophizing, which I think can also often be demeaning in some ways as a term, but it's that idea of, I'll never get better. This is the worst. I can't tolerate this. This is horrible. Which is just, this is an utter catastrophe, I think is where the word catastrophizing comes from. And then that ends up getting kind of its own problem, because we react, as physicians, we react negatively a lot to those catastrophic ideas or thoughts. But more important for this study is that the 77 studies reviewed really showed that provider biases led to real world treatment differences. Women were more likely to be provided sedatives. Men were more likely to be provided pain medication, i.e. opioids. Of course, we know that there are other pain medications. So I think that's something that we should be reconsidering, is actually how we talk about pain medications. Women's pain was attributed to psychological factors, and women's pain was taken less seriously. Move on. I'm not even going to go through this. Go on, David, because we're out of time. I did want to give a big shout out to my co-presenter, Dr. Templeton, she did a wonderful review in it was JBJS, right? Kim, I believe. So in big orthopedic, I know enough to know that's a huge journal for y'all. So, but you might be asking, but there really are differences sometimes in, there really are sex differences. And I think that was what Dr. Templeton's review, it's worth looking at, shows that yes, there are biologic factors that are different between women and men. I think she's already mentioned some of those. There's also pharmacologic differences between women and men. And this has real world clinical implications. I think my take home message from this slide is that acknowledging sex-based differences in pain is not biased. There are differences. What bias is when we make assumptions about individual patients based on these group differences, right? So it's yes, there are differences. It's okay to say that there are some differences. It's the assumptions, many of which are erroneous, and then that are what are considered biases. Next slide. I'll make this really quick. So this is my bread and butter. This is the space I love to work in. People with substance use disorders generally do not receive great care. This was another study done in 2002, just that people who use drugs, they fear that they're going to get poorer care, but also physicians. This was a really cool study, by the way, but physicians worry about deception. Physicians are not well trained in substance use, and they're not well trained in pain either. And so we all kind of avoid. Somebody will say, I'm in a lot of pain. And we say, oh, well, let me look at that foot wound of yours. We just kind of avoid the whole conversation. And next, push one more. I put this up here. I am very anti the term addict. In America, it's a very disparaging term for people who use drugs. But what patients will tell me, they'll say, do not treat me like an addict. Or I know you're going to treat me like an addict. Or I think I'm here because y'all think I'm an addict. I hear it every single week in my clinic. And what I like to tell people is, what you're trying to say is you don't want to be thought of as less than human. You don't want to be thought of as worth less than providing the highest quality care that I can provide. And what I can assure you is that I am committed to providing you the best care possible. And when I see patients who have addictions, I am equally committed to providing them with the same amount of care. People who have substance use disorders should not be treated less than human. They should not receive poor care. And that's what this statement is getting at. And it speaks to a lot of their own biases about people who use drugs. Next slide, or next thing. One thing that we can do, use different language in this space. We can keep going. There's a lot on that, but just don't use abuser, dirty urines, those kind of things. Use negative or positive urines. This person uses drugs. This person has had a return to use. This person is in remission. Next slide. These are some other things that really are communication strategies that I think can be very helpful. Mostly it's just practicing empathy. And these tend to work, putting yourself in the patient's shoes. What if it was like friends and family? I loved what you said, Rick. I won't go into much more of this. Keep going. I think in conclusion, all pain is real pain. And that's the summary take-home message. And next slide. So that maybe the next time somebody says I'm cold, perhaps instead of saying, oh no, that can't be the case, we could offer something like, I'm really sorry, come sit by the fire, and see if we get a different response.
Awesome. Thank you, Ellen. Thank you to all of our panelists. I appreciate you all being here tonight. This was a great discussion, and I know it's early this morning, but thank you all for being here. And I will conclude us now, as I don't think we have time for questions at this time. But thank each of you. This was wonderful.
Thank you so much.
Thank you, guys. Thank you for doing a fantastic work, and apologies for some initial hiccups. And thank you for being spot on.